So good afternoon and welcome to this ERKNet webinar. My name is Francesco Emma. I'm speaking from my office in Rome. As always, before starting, let me remind you that your microphones are turned off, but that during and after the webinar, you can send your questions through the GoToWebinar application that appears on your screen. I will ask your questions at the end of the presentation. The webinar will last approximately 40 minutes, and we will then have 15 to 20 minutes available for questions. So our speaker today is Professor Dagmara Borzych-Duzalka. Dagmara is a pediatric nephrologist. She's an associate professor in nephrology at the Medical University of Gdańsk in Poland. Her research focus is on childhood CKD, including research studies and clinical trials on maintenance dialysis. She is the coordinator of the International Pediatric Dialysis Registry and the Global ERKNet Registry for Pediatric Kidney Replacement Therapy. The title of her talk today is Optimizing Peritoneal Dialysis, with a particular focus on icodextrin. So please, Dagmara.
Hello, hi. I am just thinking whether you are seeing my my slide.
We see it, Dagmara. You can go. Okay. We see it perfectly.
Okay. Thank you so much, Francesco, for a nice introduction. Thank you also for invitation and allowing me to speak here. I must apologize that I don't have my camera. We were trying with Stephanie for a couple of for an hour or so just to fix it up, but apparently my computer does not work with the camera, so sorry for that. So let's start. This is the outline of my talk. So I will start with the peritoneal transport physiology, followed by ultrafiltration failure prevention strategies, which focus on PD solutions. Then I will go to the main topic role of icodextrin, and I will also briefly mention ongoing research activities in terms of perspectives of preserving ultrafiltration. Maintaining adequate blood pressure and preventing from fluid overload is a big challenge in pediatric PD, and all of us know it. This is a slide which based on the international pediatric dialysis network data, that the abnormal fluid status is the second most common cause of hospitalization after PD infections. Also, most of our patients are fluid overload, and for this reason they have left ventricular hypertrophy and so elevated left ventricular mass index. There are two clinical endpoints for peritoneal transport. The one is solid clearance and the other one is fluid removal, and there is inverse relationship between those two. So patients who are rapid transporter will commonly show ultrafiltration impairment. This is a very nice figure from Fabio Panialonga and Klaus Schmidt publication, and it demonstrates the sodium solute and water transport according to the three-pore mechanistic model. And what we can see here, the ultra small pores, the small pores, and the large pores. And according to this model, aquaporin 1 are responsible for selective water transport removal driven by osmotic force. And this transport is responsible for about 40 to 50% of the whole ultrafiltration, but unfortunately, because it is selective only for water, it causes sodium sieving, which I will discuss later. The second pores are the small pores. These are responsible for the solute and water transport, which is induced by osmotic and hydrostatic pressure. These small pores are responsible for about 50–60% of the total ultrafiltration, and these are responsible almost exclusively for all the solute removal. Then we are having large pores, where the larger molecule transfer takes place. They are also responsible for the leakage, and of course some of the fluid is absorbed into the lymphatic. Of course, we are having factors which modify the transport via peritoneal membrane. These factors are hereditary factors. These are factors which are associated with the membrane changes with using the PD solutions. These are also a function of intraperitoneal pressure and peritoneal area, which is contact with the dialysate. So what is the clinical impact of sodium sieving? Once we are having a patient with high transporter status, we are frequently performing short exchanges with high glucose, and this causes enhanced free water removal with inadequate salt removal. Those patients, because of the salt overload, will present with an increased thirst, with an increased blood pressure, and this will once again cause fluid overload. So we will be in a vicious circle. So what is the solution for it? Of course, we can increase dwell time, we can reduce glucose concentration, we can use icodextrin, which works exclusively via the small pores and has nothing to do with aquaporin 1, or we can of course also we should perform dietary counseling. What happens to the peritoneal membrane during PD? Here in the upper part of the slide, you can see a normal peritoneum with a very nicely looking mesothelial cell monolayer, followed by the compact zone, and which is filled with the mesothelial cells and vessels. Once we start PD, once we are having a patient on PD, with the time of PD, with using peritoneal dialysis solution, also because of peritonitis, we can see that there is a loss of the mesothelial cells monolayers. There is epithelial mesenchymal transition. We are having thickening of the compact zone and also intense angiogenesis. As you can see here, there are a lot of vessels here. What is the clinical implication of increased vessel density? Here we can see a paper published in 2018 by Betty Scheffer from Heidelberg, which actually shows that the increased mesothelial density, first of all, that the mesothelial density increases with time, and secondly, that increased mesothelial density is correlated to the peritoneal status. It means the higher vessel density, the higher peritoneal transport status. And once we are having high peritoneal transport status, a rapid solute transport takes place. There is a rapid absorption of glucose. If there is a rapid absorption of glucose, there is reduced ultra filtration, loss of protein, and we can end up with the ultrafiltration failure. High peritoneal transport status has been associated with, in many adult data, with an increased mortality. Of course, this is mostly due to fluid overload, but also to the high glucose absorption rate, also to the lipid metabolism. Also, high peritoneal transport status was associated in pediatric population. These are also the IPPN data with the impaired growth, which are lower growth velocity. What is the reason? Of course, it might be due to the protein, to the higher protein loss because of the high transport. So what are the factors which actually affect ultrafiltration? So the factors mostly affecting ultrafiltration is the surface area, is the peritoneal permeability, and hydrostatic, oncotic, and osmotic gradient. What does it mean when do we think that a patient has an ultrafiltration failure? First of all, we should consider the ultrafiltration failure in all patients who present with the clinical findings of volume overload. Of course, once we exclude non-compliance, once we exclude any defect in the abdominal cavity boundary, and once we exclude quick loss of residual kidney function. The reason for ultrafiltration failure is increased effective peritoneal surface area and increased permeability, and it is due to uremic state itself, it is due to peritonitis, and of course prolonged exposure to high glucose containing fluids. We are distinguishing 4 types of ultrafiltration failure. Type 1 is typically associated with the high transporter status. Type 2 is associated with the loss of aquaporin 1, with the loss of aquaporin 1, so low osmotic conductance to glucose. Type 3, this is caused by fibrosis, so reduced effective peritoneal surface area, so typically EPS. And type 4, which is associated with the high peritoneal lymphatic absorption rate, so it won't respond, for example, for icodextrin treatment. So how can we preserve and treat the PD membrane? The techniques is what can we do? We can stop PD for a while. We can start use biocompatible fluids. We can use icodextrin. We can perform adapted PD. And there are some studies showing effectiveness of blockage of the renin-angiotensin-aldosterone system, steroids, for example, for upregulation of aquaporin 1, immunosuppression in EPS, and cholinergic agent just to decrease lymphatic absorption. But what I will concentrate today, I will concentrate on the fluids, so on biocompatible PD fluids and also on icodextrin. So just a quick reminder, so we are having glucose-based or non-glucose-based solution. Glucose-based are conventional or so-called biocompatible, so low GDP, neutral pH. And among non-glucose-based, we are having icodextrin and amino acid-based solutions, so basically Nutrinil. So what are the compositions of PD solution? If we are talking about biocompatibility, we always think about pH. Conventional solution have acidic pH, low GDP, neutral have neutral pH. Unfortunately, maybe icodextrin has also acidic pH. The next what we are looking for is the glucose degradation products, and those with a lower with a very low glucose degradation products are considered as biocompatible PD fluids. Of course, it's not only pH, it's not only glucose degradation products. Solution have different buffers, so we are having lactate solution and we are having bicarbonate solution. And even when we look at the biocompatible solution, there is a huge difference because we are having lactate base, we are having bicarbonate base, and we are having mixed biocompatible solution. So what's the effect of buffer? Here we are having a paper published also by the Heidelberg group showing that buffers matters, and that bicarbonate buffer predicts individual ultrafiltration change error and is associated with a lower decline of ultrafiltration. What about GDPs? Of course, GDPs are bad. They drive local and systemic vascular disease in PD patients. Another publication from Heidelberg showing that they cause endothelial junction disruption, then they cause endothelial apoptosis, and we can clearly see that the lumen vessel ratio is impaired in patients with the high in patients who are using high GDP peritoneal solutions. So which factors play a role when we are talking about peritoneal membrane transformation? First of all, dialysis vintage. Secondly, the use of biocompatible, non-biocompatible solution, and peritonitis episodes. So in order to present our peritoneum and ultrafiltration, we should use low GDP fluids, we should treat timely and adequately peritonitis, and we also should transplant our patient as quickly as possible to lower down dialysis vintage. In this context, there was the European Pediatric Working Group suggest using neutral pH, low GDP solution as they preserve peritoneal membrane function. Their use is associated with the improved kidney residual function, and they preserve ultrafiltration. But do we really use low GDP fluid in pediatric PD? This is a graph showing the use of low GDP fluids, and it can be seen that low GDP fluids are mostly being used in the European countries, also in New Zealand, less in Canada. So and they were not used in the US. So what else can we do? So in order to preserve the peritoneal membrane function, we should reduce the high dilated glucose load. And these are the ISPD recommendation from 2021, showing or recommending the use of icodextrin to improve fluid status and to reduce fluid overload. So what is icodextrin? A short reminder: this is a slowly reabsorbed polymer which is derived from starch. It is too large actually to cross the PD membrane. 20% of it is absorbed with the lymphatics within 8 to 12 hours. It is osmotic. Ultrafiltration, which is driven by icodextrin, is slow but sustained. What is really remember that that icodextrin drives ultrafiltration via the small pores, so it's aquaporin 1 independent. the ultrafiltration when icodextrin is used is less dependent on peritoneal transport status. It has low GDP content. There are some publications suggesting, however, that there might be more rapid icodextrin absorption in small children. And in order to use icodextrin, we need a long dwell time, and you can see it from the graph here that once we are using glucose-based solution, the ultrafiltration goes down after 6-8 hours. And with icodextrin, it actually goes up. What is important, you have already seen this slide, but just a reminder that icodextrin works exclusively or drives ultrafiltration exclusively via the small pores. It means that we do not have sodium sieving, that we do not have, that our patients will not suffer from thirst. And in such a way, we can actually break the vicious circle of being fluid overloaded using high glucose exchanges which induce thirst, and once again, in spite of frequent exchanges with high glucose, our patients are constantly fluid overloaded. So what are the potential benefits of icodextrin use? Improved ultrafiltration, particularly in high transporters, reduced fluid overload, improve glycemic control. This is especially important in diabetic patients, improved lipid profile, improved blood pressure, improved left ventricular hypertrophy. It should preserve peritoneal membrane function. Because of this, it should increase technique survival and decrease mortality. Are there any evidence of that? What we can see here, this is a paper from Holmes from Kidney International Reports 2006, showing comparing icodextrin to dextrose, to low dextrose fluid and to high dextrose fluid. And what we can see here, that the net ultrafiltration both in CAPD patients and in APD patients is improved with icodextrin. Those patients had both in the CAPD and APD patients, they have a similar dwell time. And if we look at the ultrafiltration efficiency, so this is the ultrafiltration normalized by the carbohydrate absorption, we can see that the ultrafiltration achieved by icodextrin with the same length of dwell time is about 3 times higher, irrespectively if we compare it to low dextrose content fluid or to the high content fluid. Here we can see the benefits, and this is the Cochrane review showing that ultrafiltration is improved in patients which are using glucose polymer, so icodextrin, and fluid overload is decreased in patients who are on icodextrin. What about technique survival? The same Cochrane review, we can see here that the technique survival favors glucose polymer, so there is less technique failure in patients using icodextrin. This is another systematic review and meta-analysis of randomized control trials. Here we are having 17 randomized control trials with almost 1,700 participants. And we can see here that the review provides evidence that ultrafiltration is improved with icodextrin. Patients had fewer episodes of fluid overload. What is also important, that they had uncompromised kidney function despite reduction of the in extracellular volume, and icodextrin probably reduces mortality risk compared to glucose-only PD. What about blood pressure and residual kidney function? Here we are having different results, despite of the fact that in all of these randomized control trials we were having high ultrafiltration. In icodextrin group, there was in some of those trials there was an effect shown on reduction of blood pressure, and some not, and also once again different outcome regarding residual kidney function. What about children? In children, we do not have many trials. There are only a few trials with a very limited patient number. Also, in those trials, different outcome was assessed. In general, trials regards to ultra filtration, most those small trials showed a comparable or higher ultra filtration. Also, ultrafiltration correlated with age, with height, with dwell time. What is also important, there are also conflicting results on protein loss. Some papers show higher protein loss. Some patients had some papers showed no effect on albumin loss. So in this context, further trials in pediatric populations are needed. What we can see here, a publication in Pediatric Nephrology, Russo, that the dwell time volume correlates with net ultrafiltration, and according to this publication, the minimum dwell time which facilitates ultrafiltration is of 550 mL per square meters, which is sometimes difficult to achieve, especially in small children. What about icodextrin use in infants? Another publication from Pediatric Nephrology here. There were infants with a median age of 2.8 years. With duration of PD of 5 months and the median dwell time of 10 hours, and what was assessed, the reabsorption of the icodextrin, and according to this publication, younger children may have higher reabsorption from long icodextrin dwells. So what are the hypothetical limitations of icodextrin use in children? The reported limitation were associated with potentially increased risk of hypotension in the younger children, because we are removing more fluid, hyperosmolar hyponatremia from accumulation of maltose metabolites from icodextrin. Also, there were concerns about risk of peritoneal membrane damage due to the acidic pH of the fluids. Concerns of high dwell time, because the effect of icodextrin becomes relevant once we are having the dwell volume of 550. and rarely there were some adverse events like rashes reported. So with this information, there is a knowledge gap in experience with icodextrin use in children. So we decided to interrogate the IPPN database to look at the impact of icodextrin on clinical outcomes. So the objective of the analysis, which we conducted very recently, was to examine the global icodextrin prescription patterns, to compare icodextrin users versus propensity score matched glucose user, to compare patients who started icodextrin early within 1 year of PD initiation with the late use of icodextrin, to look at the longitudinal changes in volume status, to look at patient and technique survival. Of course, what was the other endpoint was the 24-hour ultrafiltration, blood pressure, and residual urine volume. So what we did, we studied all of these, and currently we are preparing a publication. The person who performed most of this analysis was Priyanka Kandeval, with statistical help from Jonas Hofstetter, and the concept of this study is by Ruxana Shroff. So what we did, we interrogated the IPPN database. So we looked at all the patients on automated PD with the data dwell. There were 3,500, more than 3,500 patients. Among these, we find out that 724 were using icodextrin, and with these patients, we performed an analysis of the prescription patterns. Among icodextrin users, we excluded more than half of these because of a very short follow-up period or incomplete data set, but we identified almost 300 icodextrin users with at least 6 months follow up. And what we did, we compared those icodextrin users with glucose users, and also we compared icodextrin users who started icodextrin within the first year of PD treatment, and those who started icodextrin after the first year. Just to compare icodextrin user to the glucose users, we performed a propensity score matching, and we matched our patient for age, sex, disease, etiology, geographic region, PD vintage, urine output, and biocompatible fluid use. So actually we performed 3 analyses, one of the icodextrin prescription patterns, then comparison early versus late icodextrin start, and comparison of glucose and comparison of icodextrin versus glucose matched users. And this is the first outcome. We looked at if you looked at the global use of icodextrin, you can see that it varies widely. Even if we look at the European countries, we can see that there are countries like Great Britain with a high icodextrin use, and let's say Germany or Spain with a lower icodextrin use. Most commonly, icodextrin was prescribed in Canada, in Great Britain, and in Saudi Arabia. If we compare this graph to the graph which present the proportion of patients which were prescribed biocompatible fluids, we can see that there is a huge difference. Actually, it means that the use or non-use of icodextrin is not really associated with the economic welfare. Please take a look at the European countries. Most of these are using biocompatible solutions, but they are not using icodextrin. So it is most probably related to the center related or country related treatment patterns, and maybe of the availability of icodextrin. This is the basic characteristic of those icodextrin users. So icodextrin users, in comparison to the glucose users, were older. They more commonly had glomerulopathies and as the underlying kidney disease. They had longer dialysis advantage. Of course, they were more commonly anuric, because this is the indication for using icodextrin. They had higher glucose exposure, higher fluid turnover, and they were more commonly on biocompatible solution. In a sub-analysis of patients with available PET data, we could see that icodextrin users had higher dialytic clearance, and also were more commonly high transporter, which is obvious. So what drives us to switch from entirely glucose-based dialysis to icodextrin? Clearly, patients who were fluid overloaded were switched to icodextrin. Patients who switched during follow-up from glucose-based dialysis to glucose and icodextrin dialysis were more commonly hypertensive. They had a lower residual kidney function, and they had higher glucose exposure. This is the effect of icodextrin of ultrafiltration, and both early start of icodextrin, it means within the first year of PD and beyond the first year of PD, was associated with the improved ultrafiltration. What about urine output? Here the slopes, the slope of urine output in early icodextrin use versus glucose users, the decline of kidney function was attenuated by the icodextrin. So indeed, in those early users of icodextrin, there was a slower decline of residual kidney function, in contrast to the late users. What about small children? We have the unique opportunity in the IPPN registry that we are really having a high patient number, and among patients using icodextrin, we had 79 patients who are below 5 years of age. And when comparing those small patients to the older patients, there was no difference in ultrafiltration between those groups. But the slope of decline of residual kidney function was more steep in patients who were younger. So what we can say based on this data, we can say that we can actually prove that we are dealing with an improved volume status in patients, especially who start icodextrin early. At the end of the follow-up, early icodextrin users had lower blood pressure values. They had lower requirement of for antihypertensive medications, and they had lower glucose exposure. Early start of icodextrin was associated with a lower diastolic blood pressure, SDS, and also with the slower decline of residual kidney function. What about technique and patient survival? Here we can also see a difference because early icodextrin start was associated with the improved patient survival, patient and technique survival. Late icodextrin start was associated with almost with more than 5 times higher risk of technique failure. So what we can say in summary, that there is a significant variation in the prescription patterns of icodextrin. Early icodextrin use improves ultrafiltration, blood pressure, and preserves residual kidney function better than glucose-based solutions. Early icodextrin conferred a 5-fold higher likelihood of patient and technique survival as compared to the delayed start. And in a subgroup analysis in small children and children under 5 years of age, there were similar changes in ultrafiltration and blood pressure SDS. So what we can conclude, first of all, icodextrin increases peritoneal ultrafiltration and improves volume status. It means it improves blood pressure and prevalence of left ventricular hypertrophy. There are possible long-term benefits of patient and technique survival, especially seen in adults. And in the prospective IPPN registry in children, we were able to show that early use of icodextrin improves volume status, patient and technique survival, that it preserves residual kidney function, and also we looked at the albumin, and there was stable albumin level, so no risk of the albumin loss. So we speculate that proactive approach of icodextrin use early in the PD course should be adopted to improve patient outcome. What are the perspective of presenting ultrafiltration? There are a few studies going on. There are xylitol and L-carnitine studies. So the elixir study with xylitol and L-carnitine being associated with the prevention of mesothelium to mesenchymal transition. Then we are having studies or toxirutine, which is an osmotic agent with suspected protective cardiovascular actions. We are having the alanyl glutamine supplemented PD study, which should improve the membrane semi-permeability. And this is the PROTECT study, which is ongoing. There are also studies on low sodium dialysate for a single short dwell time, but due to concern of the faster decline of residual kidney function, they are not yet approved. So what can we do to optimize ultrafiltration in PD? Just to sum up, we should optimize dwell times. We should optimize dwell volume. Always we should consider sodium sieving, especially in patients who are high transporters, who need short exchanges, who are on high glucose concentration, just not to get to the vicious circle of patient having constantly increased thirst and being constantly fluid overloaded. We should try to use icodextrin fluids once daily. There are also trials on icodextrin used twice, which is using twice daily. But always, if icodextrin does not work, we should consider different reasons of ultrafiltration failure. We should prevent peritoneal membrane transformation by use of low GDP fluids whenever possible, and icodextrin. There is a concept of adapted PD, which I didn't talk about due to the time limit, but there is an impact of salt and fluid removal. And of course, there are some future approach like low sodium PD fluids and the other new PD solutions. I would like to thank Ruxana, Priyanka, Jonas, who actually who did the icodextrin study. I would like to thank Klaus Peter Schmidt, Franz Schaefer for a constant support, and also all the collaborators of the IPPN registry. Of course, it is not possible to add all of these here. Thank you so much, and I would like to invite you for the next webinar. The next webinar is on the 11th of March. It is FSGS in adult by Peter Conlon. Then we are having in April consensus statement on NDI, and another one in May on lysine protein intolerance by Carlo Vinci from Rome. Thank you very much.
Well, thank you very much, Dagmara. This was a very nice presentation. I think we learned a lot, and you were extremely clear. So I'm sure that everybody has really appreciated your talk, and it was enlightening in many ways. So please, for those of you who have questions to Dagmara, please send them in, and I will ask them. So I don't have any questions right now, so let me just go ahead and start. So the basic question maybe is, when should we not use icodextrin? So this would be my first question.
Mm-hmm. Are there any contraindications for icodextrin? Maybe I will start already with some slides. One of the slides. Just a moment. Of course, we should not use icodextrin when we diagnose a patient with a high whose ultrafiltration failure is associated with the high peritoneal lymphatic absorption rate, because this will not respond to icodextrin. Also, we should be cautious when using icodextrin in very small children, due to the fact that in some studies it was associated with the protein loss, of course, in patients who are allergic to icodextrin. if we see that there are any side effects, of course, then we should not use icodextrin.
But let me just challenge you in this. You have a child that you put on peritoneal dialysis, a child that has never has never done peritoneal dialysis before. It's a small child. It needs a bridge to kidney transplantation. Would you systematically add icodextrin based on your experience, or would you only limit the use to patients that have an indication to use icodextrin?
Okay, so icodextrin. In clinical practice, icodextrin it is mostly used in patients who are high transporter. So once you are having high solute transport, but icodextrin ultrafiltration is not so icodextrin has also has been shown to be also a very good effect in patients with low transporters. It is transport independent. So in children, even though there is no typical indication with fluid overload, we always have an indication which is associated with the glucose exposure. We know that the glucose damages peritoneal membrane. So like it is done in Great Ormond Street Hospital in London, there are many patients start icodextrin early before they have any signs of ultrafiltration failure, and in such a way their glucose exposure is lower, and potentially the peritoneal membrane function is preserved longer.
Okay, so and then I have one last question is that the natural question would be, why don't we have biocompatible icodextrin solutions? And I was wondering whether you could comment on this.
To be honest, I don't know. It's more a question to the manufacturer. As I understand, your question is why we do not have icodextrin, which has non-acidic, which has a neutral pH.
Because this ideally would be the most logical thing to do, right?
This ideally would be the best solution, because actually this is we cannot say that icodextrin is absolutely biocompatible because of the potential side effects of the low pH, in spite of having low GDE content.
I think there have been some studies that have shown some initial data that were not very convincing, but I'm not familiar with this literature. But I was just wondering whether you knew more. But again, this was actually a wonderful lecture. So I don't see actually comments and questions. Usually by now, those who want to ask questions usually have sent them already. I will give you, to all of you, 20 more seconds to send in your question. You don't need to write a long text, even a very small question, before closing the webinar. I see no question coming in, Dagmara. So I actually enjoyed very much your lecture. Thank you very much. This was very enlightening, and I think we've learned a lot. And to all of you, again, I remind you the next webinars which have been planned, FSGS in adults, the guidelines on NDI, and lysinuric protein intolerance. So a very good program ahead. And thank you all for listening.
Thank you so much.
Okay.
Thank you. Have a nice afternoon.
Have a nice
Thank you. Bye-bye.
Mhm.